Hello, everyone. A very good afternoon to you all. Myself, Dr. Sumedha Gupta, and on behalf of Voice of Healthcare, I would like to welcome all the viewers who have joined us. So, today we are here to present our fourth episode of Detect to Protect, a series of awareness session in fight against the breast cancer, which is organized by Voice of Healthcare and supported by scientists. In today's session, we'll explore the vital insights on breast cancer, from recognizing the signs and symptoms to importance of early detection, prognostic testing, policy advocacy, and the latest treatment options. So let's come together to empower ourselves with the knowledge that protects women health. Before starting the discussion, I would like to share some facts about the breast cancer prevalence in India. Breast cancer in India possesses a significant public health challenge, accounting for about 14% of the global burden. This incidence is rising at 1.5 to 2% annually, with approximately 60% of cases diagnosed at advanced stages, severely impacting the treatment outcomes. The average age for diagnosis is around 45, younger than the global average of 61, and the survival rate varies 70 to 80% in urban areas in comparison to 40 to 50% in the rural regions. Awareness of the symptoms is really low, with only 20 to 30% of women informed about this disease, and less than 10% participate in the regular screening. Cultural barriers and stigma further impede timely medical help, especially for the women with a family history of breast cancer, who are at the 2-3 timer high risk. These factors highlight the urgent need for improved awareness, education, and healthcare access to address the riding burden of breast cancer in India. And in the light of these stats and facts, to begin with the discussion, first I would like you all to please join me in welcoming our experts who is going to provide us with insightful information on understanding about the breast cancer awareness. I would like to welcome Dr. S.V.S. Deo, Lead and Senior Consultant, Surgical Oncology at Apollo Cancer Center, Delhi. Welcome to the discussion, Doctor. Moving ahead, I would like to welcome Dr. Ajay Gogia, Additional Professor, Department of Medical Oncology, AIIMS, New Delhi. Welcome to the discussion, Doctor.
Thank you.
Moving ahead, I would like to welcome Dr. Nitesh, Senior Director, Medical Oncology, Fortis, Gurgaon. Welcome to the discussion, Doctor.
Thank you
Moving
very
ahead,
much.
I
Really
would like
looking
to
forward.
welcome Dr. Rajiv.
Thank you.
I would like to welcome Dr. Rajiv, Senior Consultant and Chief of Breast Services, Rajiv Gandhi Cancer Institute, Rohini and Niti, Bagh, New Delhi. Good afternoon, Doctor. Welcome to the discussion.
Thank you.
So let's begin with the discussion. So, if we talk about the signs and symptoms of the breast cancer, I would like to know your views, Dr. Deo. What are the most common signs and symptoms of breast cancer that the women should be aware of?
Yes, Sumedha, that's a very important issue when you are talking about awareness of breast cancer. Most of the early breast tumors are actually very silent, they don't cause any symptoms. So, when you talk of signs and symptoms, the tumor is already grown to a particular size. The most common symptom the woman should be aware of is any change in the size and shape of the breast, any recent lump which has been noticed which is growing steadily in size, any discharge from the nipple, any change in the skin or any wounds on the skin, ulceration, nipple discharge, any swelling in the armpit or any swelling in the arm. So these are the common features of breast cancers. But remember, most of the early breast cancers are silent. So what we have to do is not only awareness, but we'll be discussing about screening little later.
Thank you, Dr. Deo, for these insights. Moving ahead with the sign and symptom parts to Dr. Ajay, I would like to know your views. How can women differentiate between a normal changes in the breast tissue and the potential warning signs of the breast cancer?
And there are 4 or 5 warning signs for the breast cancer, which we know and which teach other the students or subjects. The first warning sign is the skin changes, like the the skin of the breast is like orange peel appearance, is called as POD orange. Second is dimpling or puckering. Number 3 is nipple retraction, and number 4 is any lump or bumps in the armpit. So there are four warning signs which we can differentiate for the normal breast or any breast benign breast disease to the breast cancer. So these are the four warning signs for the breast cancer.
Thank you, Dr. Ajay, for letting us know. Moving ahead to Dr. Nitesh, I would like to know, are there any specific demographic groups that should be particularly vigilant about recognizing these symptoms? And it's more, and the prevalence is more towards that.
I think let's divide that question into three parts. One is the common group all across the world, and we usually believe that breast cancer is commonest around 70, so 60 to 80. But we are seeing a very different demography in India. We see younger age group by almost 10 to 20. We are seeing it even under 40s. So, young breast cancer is more common in India. There have been people saying it's the capital of the world. So I would get suspicion even as young as 40 years of age. A third very important group, which is often ignored and not discussed, in fact, is family history. We used to think that familial breast cancer is not common in India, but I think that was a myth. The more we've looked into his family history, and breast cancer is looking like it's common in India. So, in brief, anybody whose family, mothers or sisters or aunts have breast or ovarian cancer and other cancers should be suspicious of a lump in the breast and all the things that have been said by Dr. Ajay and Dr. Dio. But generally, I would advise certainly screening from 50 and even earlier. So everybody's at risk.
Dr. Nidesh, I would like to know a more one follow-up question onto that. I mean, is there any difference in the prevalence when we compare about the rural area and the urban area?
So that's also true, Sumedha. We know that breast cancer is a disease seen a lot more in the cities than in the rural area. Of course, it is related to lifestyle, including delayed childbirth, breastfeeding, and questions like that, along with obesity and lack of exercise. But the difference is clear. But I don't think that should be a reason for a patient in the rural area to not suspect that this could be a breast cancer if there's a lump. So essentially, I'm saying that, including self-examination, that everybody, unless you take it as a universal thing, unless you do not focus on that question whether you're prone or not, you will not pick up early breast cancer.
Thank you, Dr. Nitesh, for these insights onto that. Moving ahead with the discussion to Dr. Rajiv, can you please explain us what steps should a woman take if she notices any unusual changes in her breast?
So the breast keeps on changing throughout the life cycle of a woman. You know, so every menstrual cycle, the breast gets prepared to feed the baby. But if there is nothing like that, then it goes back to its normal position. So in every menstrual cycle, there is a change in the breast, and the lady herself knows what are the changes in her breast in every cycle. So whenever she feels anything abnormal to that regular changes, she should report to a doctor. More than that, if there is any, she feels any abnormality in the form of the symmetry, both the breasts are not similar. There are some differences in the breast. If there is any asymmetry in the breast, or there is a lump, or the new nodularity, anything new she feels, she should go to a doctor and get her checked up, particularly to a surgeon or a breast surgeon or someone who knows about this disease. Unfortunately, what happens most of the time they go to the gynecologist, and sometimes the lesion is missed or it has been ignored, like a milk ki lump hai ya kuch aur hai. So one should see the right person whenever a lady feels anything abnormal in her breast, which is routine in her menstrual cycle.
Thank you, Dr. Rajiv, for these insight. On following up of that, I would like to know your views. I mean, how it's important to discuss the normal fluctuations that occur in the breast throughout their menstrual cycle. I mean, how to identify these concerning changes that they are alarming or not.
You know, before every period, the breast become little engorged. they become heavy and go. There's some pain in the breast. As the periods when goes off, then all these things gradually disappear and breast become again soft and supple. So this is the regular change which every lady who is menstruating feels in her life. So any change from that pattern, one should be alarmed.
Thank you, Dr. Rajiv, for these insights. Moving ahead with the discussion to screening and self screening techniques, I would say to Dr. Deo, I would like to know what are the recommended guidelines for the breast cancer screening, including the age and the frequency.
Breast cancer screening, now we have almost 4 decades of experience globally. So the guidelines keep changing. The latest guidelines of American Cancer Society and US Preventive Task Force recommend screening for any women starting at the age of 40 years. It used to be 50 years before, but with the changing demographics, now the age of screening has now shifted little early. So it has to be started at the age of 40, and it's recommended every 2 years. A screening mammogram has to be done till the age of 70. So these are the guidelines which are normally followed in Western countries like North America and Europe, Western Europe mostly. In India, National Cancer Screening in India right now, but we encourage opportunistic screening. What we are encouraging in India is awareness of breast cancer, early detection, and clinical breast examination. So that is integrated in the National Cancer Control Policy. So the ANMs and nurses at the primary centers and secondary centers are trained for early detection. So that is what India is currently following. But we also encourage opportunistic screening in big cities where women can access easily the mammographic facilities, the biopsy facilities. So we are encouraging them to go.
Thank you, Dr. Dev, for these insights. In the following up of that, I would like to know your views onto that. I mean, how we can encourage the women about the screening, how we can aware them about the screening. I mean, if we talk about the self screening and how, what is the frequency to do the screenings?
Yeah, we have basically, you see, first campaign is the breast awareness campaign. Awareness means know your health, know your breast, how a normal breast looks like, and how to pick up the early features, signs, and symptoms of breast cancer. So this is awareness campaigns normally we do. As you know, this is October is the month of breast cancer awareness. So that is where a lot of NGOs, it's not only doctors, the public health experts, the media, everybody is doing a lot of programs at the community levels. So that is where we try to encourage to promote the breast awareness, breast health awareness, and early detection. The second issue is coming for organized screening that I think the individual hospitals and state health authorities are normally implementing these programs. So this is done at a community health centers or at a tertiary care hospitals where all the expertise is available. And patients have to be really educated regarding the benefits of screening of breast cancer. That is the most important issue. What is the importance of early detection, how we can save lives, and how we can simplify treatment. I think the benefit
Thank you, Dr. Dev, for these valuable insights onto that. Moving ahead with the discussion to Dr. Ajay, I would like to know, please tell us about how can the self-examination technique should be done and how often should women perform it?
And self-examination of breast is very important, especially in the rural area where the most of the clinical expertise is not available. So, self-breast examination, the age should be started from the 18 years of the age, and the timing is very specific. For the premenopausal woman, it should be within a 1 week after the period or after the menstrual cycle, within a 1 week, any day specific day, and postmenopausal women, any day of the month. So it should be done monthly. It started with the age of 18 years, and it started in the standing or sitting position in the front of mirror with the pulp of finger in the middle three finger, like this three finger is suffice. We can do this by either by the inspection. With the inspection we know the size, shape, and symmetry of the breast. Any changes in the size, shape, and symmetry. And second is by palpation. And by palpation, we do the clockwise direction of the outer quadrant, inner quadrant, and the lower quadrant in the clockwise direction. And last with the nipple areola complex. And last thing is with the squeezing of the nipple to see the discharge. And after this, we go with the axilla of, on the same side or opposite sides axilla and see the notice of the any lumps by the palpation. So we should consider both the breasts simultaneously, each after one after without any gap or without any delay in the days or any month. So it should be done with a specific time period in pre and post menopausal in the starting with the age of 18 years in sitting or standing position with the pulp of fingers.
Thank you, Dr. Ajay, for telling us about how to self screen and what should be the frequency. Moving ahead with the discussion to Dr. Nitesh, can you please tell us what role do the clinical examination play in early detection? And also, please explain us with the different diagnostic methods for the breast cancer and how often they should be conducted.
Now, I think you're talking now post screening and diagnosis of breast cancer. The key diagnostic modality there is what we call examination, radiology, and a biopsy or FNAC, ideally a biopsy. And that examination is critical because, end of the day, the scan is a shadow, very critical. There's still a shadow. It's a combination of an examination and the scan, which gives you somewhat the volume of the disease and the lymph nodes. And it is the biopsy or the FNACs, especially the biopsy, which gives you the nature of the disease. Now, once you've confirmed the diagnosis by a critical clinical examination, thorough examination, by an experienced hand, and a mammogram as an ultrasound, we have to decide what else to do. And Sumedha, that's not an easy question. I mean, it's not one thing fits all. So I can't really answer what all test for who all. Their patients will need MRI, will need a PET scan, will need a CT scan, and others who will just need an X-ray and an ultrasound and nothing else, depending on stage and biology. And same way, the frequency of further testing can vary from every few months to few years to not at all. But at least a mammogram as follow-up once a year is considered critical and is by guideline. So I think this is something which your doctor has to guide you of the frequency of testing. But the diagnostic testing always will involve an examination, a biopsy, maybe an FNAC, certainly a biopsy in my mind, and radiology, mostly in form of a mammogram, ultrasound, and mostly some kind of a scan, like an ultrasound or bone scan, to see whether there's metastatic disease or not.
Thank you, Dr. Nitesh, on these insights. On following up of that, I would like to know that most of the people out there are very scared, or I would say there is the stigma of having the biopsy done, the testing done. I mean, how we can encourage and should provide them knowledge that these tests are important and they are these are being done for their good only. I mean, how we can encourage that in the people out there.
I think there are two different questions you are asking there. One, there's been a myth in society, and that's a reality that the myth in society is more than the reality in society. We surrounded by these things. Um, and you can't answer these things. We have data to show that's not the case. But cynicism, there's no solution to that. But I ask my patient when they ask that question very simply, that you'd rather fall prey to myth or have a certainty of diagnosis and therapy. Every patient understands that in today's day and age, your best treatment comes by a complete understanding of the spread of tumor, which is the radiology, and the biology of tumor, which is the biopsy. And without any of these being done and thoroughly done, I may add, you will find that your outcomes are poor. So you can choose whether you want to fall prey to myth and compromise your outcome, or you want actually exactness of science, which is followed all over the world. And I think there are numerous data to suggest that biopsy does not change outcome in terms of curability or control of cancer. So I would not fall prey to that.
Thank you, Dr. Nitesh, for such an awareness. Moving ahead with the discussion to Dr. Rajiv, I would like to know your views on screening and early diagnosis of breast cancer. And are there any emerging technologies or methods in breast cancer screening that show promise for improving the detection rates? Uh,
Well, the standard method of screening for breast cancer remains mammogram. That is the standard method. But mammogram is only helpful in those who are 40 years and above. Less than 40 years, mammogram is not that helpful. Unfortunately, these days, many of our patients are coming which are very young, maybe in 20s, 30s. They are coming with dense breast, recently pregnant, or recently married. So in those cases, mammogram might not help. For those, MRI is the best way. Whenever you have suspicion, do an MRI or a mammogram in more than 40. And even ultrasound is a very good tool. Although it has not been a standard of care, a standard for doing screening, but it's a very good tool to at least find out whether the lumps are solid or cystic and what is the nature of the lump. And if there is suspicion on ultrasound, one can go for an MRI. So for less than 40, either ultrasound or MRI. These days, some tomography is also there, which can be done. And more than 40, mammogram, standard mammogram, screening mammogram, are the standard methods to do screening these days.
Thank you, Dr. Rajiv, for letting us know about the screening process. Moving ahead with the discussion about the importance and methods of early detection and the diagnosis, I would like Dr. Deo to please tell us about what is early detection critical in improving the breast cancer outcomes and how it shapes the treatment methods.
Yes, you see, it's the breast cancer treatment and outcomes are dependent on the stage. So the earlier the stage, the better of the outcomes, the simpler is the treatment. So we have now a lot of data available all over the world. The stage one breast cancer, if you treat the stage one breast cancer at stage one, the cure rates are almost 90%. You can cure these patients. I'm talking in the breast cancer, we talk about 15, 20 years cure rates, not like other tumors where we talk of 5 year survivals. So for stage two, the cure rates will range between 70 to 80%. For stage three, the survival falls to almost 50 to 60%. So that is the importance of staging or the stage at the time of diagnosis. That will determine your survival and also your treatment planning. The earlier the stage, the simpler is the treatment. You can save the organs, you can save your lymph nodes. There's no need for radical mutilating surgeries, and you can also optimize your medical management and radiation managements. So we are in the era of currently de-escalation of breast cancer treatment, where we are trying to minimize the side effects, decrease the intensity of the treatment, but without compromising on the treatment, the survival outcomes. So that is why stage is extremely important. That is why most of the campaigns all over the world, for example, in US, the breast cancer survival currently is touching 90%, whereas in India, the breast cancer survival is currently 55%, 50 to 55%. So that is mainly because of the stage at the time of diagnosis.
Thank you, Dr. Deo, for these insights onto that. And I think people should be more aware about it at the earliest as possible. Moving ahead with the discussion to Dr. Ajay, please tell us about what methods are currently available for the early diagnosis and how effective they are.
And for the early diagnosis, the only method is mammogram. As previous speaker already told us, the mammogram is the standard of care for the early diagnosis. But in the young women, with the pregnant women, or any other woman with a dense breast, MRI is the standard. But mammogram and MRI, the both the tool are very standard for the early detection. But the guidelines showed that the mammogram is still valid after 30 years of age. Second, if we have the family history and BRCA associated tumor or any BRCA associated family members, then the guidelines showed that 25 years of age is the starting point of any screening, annual mammogram alternate with MRI. So this should be standard of care in BRC associated families. But the other family is the low risk women. The standard is around after 40 years till the age of 75 years, annual mammo or mammogram every 2 years is sufficient. So only two techniques or for the early diagnosis, mammogram and MRI of the breast. That's it.
Thank you, Dr. Ajay, for these insights. Moving ahead with the discussion to Dr. Nitesh, please tell us about how can health education campaigns improve the public understanding or the importance of the early detections when it comes to breast cancer.
Sumedha, I may have a very tangential view on that actually. I am of belief that people who are made aware of the problems don't get aware of the problems. I think we miss the link. Telling people a didactic lecturing in the class does not help. It is a tutorial. So we do a lot of campaigning, and I think it does raise awareness. I think people are aware that breast cancer can happen. But that was never the question. The question is, are people aware that breast cancer can happen to me? And that reality is still not sunk in, that every woman in India today who is over the age of 40 to 75, and if your family is still even younger, is at risk. Now, just telling them this will not help. So, I think breast cancer awareness campaigns are very important to keep the talk going, but I don't think they alone help. I think the government and us together have to somewhere put our hands together and find innovative ways, incentivize people, find insurances, health insurance schemes have to be drawn and insisted that you get insurance rebates if you do screening regularly. I don't know why most private insurances and government insurances in India still don't have a dictum that you must screen to at least get a rebate on your insurance every year. Why is the rebate only on a car when you don't claim a bonus? Why there is no claim bonus on the car and no health screening on the insurance scheme? So we have to innovate. We have to propagate a different way. And when we do that, we also create a very stark noise because you're doing something different. A patient standing in a public place today will hear about breast cancer can happen to you and will not be surprised. They've heard that before. So I do think that we need to keep on talking about it, but I think we need some very new ways of doing it. I think our ways that we are doing today are failing.
Well, very rightly said, Dr. Nitesh. Moving ahead with the discussion about the family history, I would like Dr. Rajiv to please tell us about what role does the family history plays in early detection and diagnosis, and how should individual approach this with their healthcare providers.
Well, family history has got a very, very important role in breast cancer. And we know if there is a positive family history, there are higher chances of having breast cancer in the lady or the man. So the most important thing is when we take family history, it is important to take family history on either side. It's not only maternal family history. It is paternal family history is equally important, in particularly in the transmission of BRCA gene. See, if the BRCA gene is positive in the one of the parents, the 50% of the children are supposed to have those Ds in inheritance. So paternal history is as important as maternal history when we take family history. Any first degree relative which is involved, either on either side, it is important. And when the family history is there, and then if those people who have got disease, they were tested for some genetic test like BRCA1, 2. And if they are positive, their siblings and their what you call children should also be tested when they are 18 years and above. This is important. And then once you are positive, you are high risk due to family history, the screening should start little earlier than the normal stage of than the normal age of screening.
Thank you, Dr. Rajiv,
Sumedha,
for these
can
insights.
I just add? Can I just add a little bit to that? Dr. Kumar has said
Yes.
something very pertinent, uh, and I think what I want to add to that is please ask more definitively. I have had lots of patients where I said, "Is there family history?" and the answer is no. But when they ask, "Do you have your aunt's daughter or your on either side, paternal or maternal, bua or masi's daughter or mama's children?" They say, "Yes, yes, there are two of them." So the patient don't really know even what family history means. So important to be elaborate about it. That's the only point I was trying to make.
Yeah. Yeah, I think yes, extended family history should also be considered while doing this. Moving ahead with the discussion to genetic testing and risk assessments to Dr. Deo, I would like to know your views. Who should consider the genetic testings for breast cancer and what factors should influence their decision?
You see, the awareness regarding genetic factors, as I think we see a good awareness is coming in the last 1 decade. We have a better understanding of breast cancer genetics. We have a better understanding of genetic testing, whom to test and when to test. So now there's a lot of clarity. So, as a layperson or a general physician who is dealing with these patients or an oncologist, there are certain red flags which you have to be careful when you're taking history of a patient, which will direct you to go for genetic testing. Counseling first, followed by testing. So these include any breast cancer in a younger age patients who is less than 45, breast cancer, history of breast cancer or ovarian cancer in the first or second degree relatives in the family. That's very important. Our previous experts have highlighted right now what these members are. And history of early onset breast cancer, history of triple negative breast cancer if you are less than 60, history of breast or ovarian cancer in the first or second degree family members, any male breast cancer, we normally recommend genetic testing, and any past history of breast cancer or ovarian cancer in the same patient. If they are developing a second tumor, that is also an indication for going for genetic counseling first, followed by genetic testing. So these are the simple factors which can be taken in the history or while doing the assessment of the patient during in a routine clinical assessments. So once you see these kind of features, we should start at least discussing the genetic counseling part and testing part that has to be a part of your routine management strategies in any breast cancer clinic in India right now.
Thank you, Dr. Deo, for these insights. Moving ahead with that, to Dr. Ajay, I would like to know what specific genes are commonly associated with increased risk of breast cancer genetically and what do the latest results mean?
So, ma'am, around 10 to 15% of the breast cancer are usually hereditary. So, out of this 10 to 15% of all the cases, 85% are associated with two genes only, that is BRCA1 and 2. So, these two genes are very important, and BRCA1 and 2 genes are both are highly penetrance gene, and rest of the 15% are like check P10, Cowden, PAL B2, and RED1. These are the 5 or 6 most common gene associated with uh, breast cancer related to hereditary pattern. But the most important thing is out of these 6 or 7 genes, there are so many, there are 230 genes, but their actionable mutations is only 6 or 7 genes. Actionable mutation means which can lead to our therapeutic decision based on these 2 or 3 or 5 genes. Like in BRCA1 and 2 gene mutation, we have more of 2 or 3 drugs which were used in either early breast cancer or metastatic breast cancer if BRCA1 and 2 mutation genes are present. Suppose SPALB2 gene or RAD 51C gene present, then we can offer him prophylactic risk reduction surgery and other means also. But so these 5 genes are very important before the diagnosis of breast cancer or after the diagnosis of breast cancer. So we will plan our management according to these mutations. For example,
Yes.
BRCA1 2 mutation, this is and PARP inhibitor. If
पहले
other gene
patient भेज
present, surgery. There are upcoming data of the PARP inhibitor in PALB2 and RAD1 to 5 genes, but the data is not mature.
Thank you, Dr. Ajay, for these knowledgeable insights onto that. Yes, please continue.
I said these are the targetable mutation and the all the modality based on the these gene present, yes or not. I said already in early breast cancer, in metastatic breast cancer, BRCA12 is mutation is present. Then the PARP inhibitor is a very big role in the play, very big role in the survival benefit of 4 to 5%. And top of that, risk reduction surgery is very important in other mutation, actionable mutation like PALB2 and RED15 and ATM mutation. And based on these other screening members,
Thank you,
other
Dr.
family screening to be done accordingly.
And I mean, what should be the frequency or awareness about it when it comes to the genetic testing for the people if they have this extended family history and their maternal and paternal side has these histories?
Are you asking me, Sumedha?
Uh,
So,
yes, please explain.
okay. Okay. I think you're asking frequency of testing if somebody has a family history, not the frequency of test, because the test for BRCA1 and BRCA2 and other things Dr. Gogia very elaborately put is done once in a lifetime, and either you have it or you don't have it. But if you have it or you don't have it, you have to be through the counselors that Prof. Dio was talking about. You have to go through a structured program of screening, which could include mammogram, ultrasound, and so on and on. Now, the genetic counselors are the best people to recommend that because based on the strength of your family history, the mutation you have, and what Dr. Gogia was not trying to speak about because this is not a scientific forum, but even the number or the exact number of the mutation on BRCA, there will be a variation in what is advised. Ballpark, you classify patients into risk of breast cancer, ovarian cancer, uterine cancer, colon cancer, and say whether it is 20%, 40%, 80%, 10%, and based on each of that, there's a guideline to screen from colonoscopy to ultrasound to examination and so on and on. Again, I would say the frequency is variable, but if somebody cannot go through that detail, I would certainly keep doing what is recommended, which is once in a year to 2 years mammogram and ultrasound breast, especially in young women where mammogram can become difficult. Colonoscopy every 3 to 5 years, especially if there's a history of polyps and colon cancer, cervical cancer screening every 3 years, and then ultrasound whole abdomen to some extent if the uterine cancer and other cancer at risk. Although a lot of this, at least the last ultrasound, is not evidence proven, but evidence is not being collected in India anyway. So I think that's just a commonsensical view.
Thank you, Dr. Nitesh, for these insights. And if we talk about risk assessment, are there any risk assessment tools or maybe diagnostics that help in understanding an individual likelihood of developing the breast cancer?
So that's exactly what Dr. Gogi and I together trying to allude to. You first do a genetic screening with a counselor. You see what kind of test you need to run. Then you need to run the test. Then you get the results. Then you have a post-test counseling, and then the post-test counseling tells you what are your risks, and that becomes a structured system. It cannot be one test fits all again approach. And based on your risks that come out, you have to advise a certain screening for the rest of your life.
Thank you, Dr. Nitesh, for providing us with these insights on these risk assessment overall. Moving ahead with the discussion to Dr. Rajiv, I would like to know your views. What options are available for the individuals to identify at higher risk due to the genetic factors?
So higher risk means the lady has got a higher chance of developing breast cancer or ovarian cancer in her life as compared to normal individual. But if she's BRCA positive, it is not 100% that she will develop these cancers. So first important thing is one should reassure that person that you are BRCA positive, you have got higher chances of having cancer, but it's not that you are 100% you are going to have cancer. One. Two, there are other ways and means by which you can tell them, like surveillance is one of the ways. We can do surveillance for these patients, and then one can offer them risk reducing surgeries like bilateral mastectomy with reconstruction. And then more important than risk reducing mastectomy is doing bilateral salpingo-oophorectomy. Why it is important? Because breast is a superficial organ. There are so many ways and means by which one can detect breast cancer in a very early stage, by mammogram, by MRI, by ultrasound, by self-examination. There are so many means. But ovarian cancer, if they present very late, in stage 3, and those things should be prevented, and that is more fatal as compared to breast cancer. So all these patients, if the family is complete, then they should be suggested for risk-reducing salpingo-oophorectomy. It can be done laparoscopically very easily, very small surgery, and there is no problem. So risk-reducing mastectomy, risk-reducing salpingo-oophorectomy, and surveillance. These are the three methods for them. And then reassurance is very important, that it's not that you are going to get cancer. We are doing these surgeries to reduce the risk of the cancer. And even after that, even after doing risk reducing surgeries, there are not 100% chances that that patient will not develop cancer. So these are the ways and means by which we can treat these patients.
Thank you, Dr. Rajiv, for these insights. Moving ahead with the discussion about the prognostic testing, I would like to ask Dr. Deo, what is the prognostic testing and how does it differ from predictive testing in the breast cancer? Dr. Deo, am I audible to you? Moving ahead, I would like to ask Dr. Ajay about this. I mean, what is the prognostic testing and how does it differ from predictive testing in the breast cancer?
The prognostic test is depend on the tumor biology, and the predictive test depends on the how the patient react with the that treatment. For example, the prognostic test in the breast cancer, the most common prognostic tools, which is clinical examination, either node is positive and tumor size is more than 5 centimeter and any skin changes. This showed that it is a locally advanced breast cancer and the prognosis is poor. So the clinical stage is very important prognostic tool, followed by ERPR is a estrogen receptor and progesterone receptor, HER2 receptor, Ki67 grade. These five common prognostic tools, and these five prognostic tools are also predictive. Like patient is, if ERPR positive, then it is very good responded with hormone treatment. If HER2 3 positive or HER2 positive, this very well responded with the target treatment. Suppose patient is another kind of prognostic tool. Suppose patient has B.R.C.A. 1-2 mutation, then patient has lifetime risk of another breast cancer is around 60% and 40% is ovarian cancer. So these are the prognostic tools, and predictive is where the uh, patient control with the treatment is the treatment outcome is the predictive, and prognostic is the patient is baseline clinical features and clinical pathological features are the usually prognostic.
Thank you, Dr. Ajay, for telling us and differentiating us between the prognostic testing and predictive testing. Moving ahead with the discussion to Dr. Nitesh, I would like to know how can prognostic test influence the treatment decision and the patient management and outlook?
So I think prognostic tests are very critical in terms of our ability to warn the patient of what are the likely outcomes in treatment. Some very basic testing happened many years ago was ERPR, HER2 triple negative versus ER positive, simple testing, and now of course we have some more elaborate for hormone positive node negative patient oncotype DX. We have an Indian equivalent Canasys, and all of these to some extent help to decide whether the risk of cancer coming back is high and low. So A, the patient needs to know. But B, also to intensify treatment or not, to consider things like chemotherapy or not, makes sense only when the prognosis is poor because it's a relative benefit. If somebody has a 30% benefit and you can reduce by 10, you reduce by 30, then you're saving 10 lives. but somebody has a 6% benefit and you're reducing by 30, you're saving two lives in 100. So it does make sense treating. So I think having prognostic test allows you to explain to the patient what their reality is, but also helps the oncologist to decide the intensity of therapy that needs to be given to people or not given to people, more importantly at times.
Thank you, Dr. Nitesh, for telling us about this. Moving ahead with the discussion to Dr. Rajiv, I would like to know your views. How accessible are prognostic testing options for patient in these days and in different healthcare settings, and how does it influence the treatment method, patterns and methods?
So these prognostic tests, as Dr. Nitesh has told, Oncotype D, CAN, Assist, and so many others, they are readily available these days. But unfortunately, most of the international tests are very costly, and most of our patients cannot afford them. Of course, this Indian test CAN Assist, most of the people can afford. Rest of the patients, we have to tell every patient about these tests, but most of the patients may not be able to afford those, like Oncotype D, is costing around 3.5 lakhs. So that much amount they don't want to spend on testing itself. So that is the problem, but they are very good actually. In my experience, we have done so many of these tests, and those who are hormone receptor positive and HER2 negative, and those who are on low risk, they can be avoided any kind of chemotherapy and can be treated only with hormone therapy. So in a way, it's good for very good for patients to get these tests done. So ideally, all patients who are low early breast cancer and ER positive, HER2 negative should undergo these tests.
Thank you, Dr. Rajiv, for providing us with these insights. Moving ahead to the treatment part, I would like to know Dr. Ajay's view on like what are the current standard treatment options for breast cancer and how they have been evolved in recent years. And if you want to tell us about any recent development or latestment into that.
So broadly speaking, the breast cancer is divided into three groups. Is one is hormone positive group, another is triple negative group, and third is HER2 positive group. So overall, all these three groups, when as a medical oncology point of view, the current standard of care is dose dense chemotherapy in triple negative and hormone positive, and HER2 target therapy, dual target therapy is good in uh, HER2 positive breast cancer, either locally advanced, early breast cancer, and metastatic breast cancer. This is the standard of care is currently practiced all over the world. In triple negative breast cancer, dose and chemotherapy followed by surgery. If residual tumor is there, then role of capecitabine for 1 year is standard of care. For HER2 positive disease, early and locally breast cancer, dual target therapy with chemotherapy, followed by surgery and followed by maintenance target therapy is the current standard of care. Same as hormone positive disease, dose and chemotherapy followed by surgery and followed by 5 or 7.5 years of hormone treatment suffice. For the hormone positive disease, as the previous speaker told, there is a subgroup of patients which will benefit, which not benefit with the chemotherapy. We can go for the prognostic. This is not exactly prognostic test; it's a recurrence score. Then patient can avoid the chemotherapy in some extent with either by the Oncotype DX or mamma print of Indian version of other tests. Second, the third thing is the recent advances in the breast cancer in the current 2 or 5 years in the hormone positive disease because of the some prognostic or predictive markers like in hormone positive disease, PIK3 mutation, ESR1 mutation, or PTEN mutation. Three mutations are very targetable with the current standard of care or other drugs in hormone positive disease. In HER2 positive disease, there are so many advances like dual target therapy along with the deruxtecan, along with the tucatinib or lapatinib or TDM1. There is so many basket of HER2 target therapy along with the niratinib. And triple negative breast cancer, in the current era of immunotherapy, the survival is improving in the triple negative breast cancer in both metastatic and early breast cancer in the tune of 4 to 5% in the recent published literature of immunotherapy in triple negative breast cancer. So the recent and definitely the breast cancer is relatively challenging, and because of the targets in different subset, the survival outcome is very good. For example, like in triple negative breast cancer, there is no target in the last 4 or 5 years, but the advent of immunotherapy, with the advent of PARP inhibitor, the survival is improving in triple negative breast cancer also. And second and third line, a role of sacituzumab and other drugs is upcoming. And sacituzumab is very well in triple negative breast cancer, and we are doing trial and very good outcome with triple negative breast cancer with sacituzumab. Like in HER2 breast cancer, there are 2 or 3 trials are going on, and 3 drugs is very upcoming, and one is our trial is ongoing on HER2. It's very promising drug in HER2 positive breast cancer. Again, like in hormone positive breast cancer, 203 trial is ongoing in AIIMS with the PI3 inhibitor and ESR1 mutation, which definitely improve outcome with these targets.
Thank you, Dr. Ajay, for providing us with the different treatment methods. And I think it's really enlightening to know about the latest developments in breast cancer treatment. Moving ahead with the discussion to Dr. Nitesh, I would like to know your views on how to personalize medicine and targeted therapies change the landscape of breast cancer treatment.
So I think that's a very important question, and there's a bit of an overlap with Dr. Ajay said. He enumerated very comprehensively everything new that's happening in science in breast cancer today. But a lot of choosing what to do with which patient is dependent on what the patient has. And our science has become smart enough now to take the cancer DNA, even from the blood itself, not only from the tissue, and analyze the abnormalities on surface, under the surface in the DNA, and see which are the pathways which are really both making the cancer cell, but also more importantly, driving it to become more aggressive or resistant to the previous treatment. Now, once you start understanding to that level of depth of where the problem lies, where the cancer is becoming a real cancer, you of course start picking up solutions, some of which may be drugs. For example, Dr. Gogia spoke about NHER2, which is a classical HER2 drug, but we are finding that if the similar amplification is happening even in lung cancer, or a much lesser amplification or mutation happening in breast cancer, 1 plus, that same drug works. So personalized medicine is a new way of looking at the cancer cell and the blood sometimes, as I said, finding the target and saying what therapy from the past or a new research molecule can attack it so that either the cancer gets contained or abolishes. And I think this science is in its very incipient stage. We think it's really got advanced, but I think it's literally on day one. And we'll see a lot more as we understand the interactions between the different pathways in the future.
Thank you, Dr. Nitesh, for these valuable insights onto the personalized medicine and treatment part. Moving ahead to Dr. Rajiv, in the end, to conclude, I would like to like you to please tell us any advice or any recommendation you want to give to the patient out there who are newly diagnosed with the breast cancer and at the verge of this disease. Dr. Rajiv, am I audible to you?
Can you repeat the question, please?
Yes. In the end, to conclude, I would like to please tell us or advise us, recommend the patient out there who are newly diagnosed with the breast cancer and are at the verge of this disease. What advice you want to give and what recommendations?
The simple thing is have faith in the right person and do the right thing which has been told by you. So you go to the right person for the treatment, and the treatment is almost now mathematical. Like when to give chemotherapy, when to do surgery, when to give radiation, when to give hormone therapy. Everything has been chalked out very nicely by the different guidelines. So there's not much difference in choosing the treatment part. Of course, in surgical part, yes, there's some decision making which is important for the patient, that she has to decide what kind of surgery she wants, and what are the various options for surgery are there. The unfortunate part is that the poor lady does not have much say in that thing. Most of the time, some relatives tells him, get this done or get that done, right? So have faith in your doctor and do go to the right person, have faith on him, and follow whatever he or she advises. That is the right way of tackling any cancer.
Thank you, Dr. Rajiv, for your advice and recommendations. In conclusion, our objective for today's discussion was to explore and emphasize the importance of breast cancer by integrating insights on recognizing the signs, symptoms, the significance of detection, screening methods, treatment options, etc. And I'm confident that our experts have addressed this crucial topic comprehensively and effectively, presenting in a way that laymen can also understand and it's accessible for her as well. I would like to extend my gratitude to all the panelists for their insightful contribution and for sharing your expertise with us today. Your participation has been really valuable and we deeply appreciate the time and the knowledge that you have shared today. Thank you for joining us and contributing for this important conversation. Thank you so much.
Thank
Thank
you
you,
for
everyone.
having
Thank
us.
you.